this might actually be the mic. Yeah, this is okay. The incredibly tiny.
Do you have 3 mics?
Just two.
Oh.
But it's a different one.
Oh, that's the
So, yeah, that's for the
live.
live streaming, he said. Okay,
Do you need a laser pointer?
I don't, but I don't know if there's if it's a problem. No, don't worry. But if there's any water, it'd be great if I could get water. Okay, thanks, Ian.
So
we'll start a minute or two after 11.
Sure.
Jim will do the introduction, say a few things about Danny Campbell.
Yep.
And then the podium is yours.
Excellent.
And if you can leave maybe 10 minutes at the end.
Yeah, that's what I'll try. I'll keep a close eye and try not to go too speedy. I just cut out a few slides to try to make sure we had time for discussion. So.
The audience really loves this.
Yeah, excellent.
If Peter Whitehouse was here, he always likes to moderate Q&A. If he's not here, then either Jim or I will do it.
Okay.
And you never know in advance whether it's here.
Keeps you guys on your toes. Exactly. All right. Thank you.
also for the Q&A, Jenna will be running around with the microphone.
Got it. Just wait for people to...
Yeah, if they do talk before the microphone, which they do, if you wouldn't mind repeating the question.
Sure.
Okay. Awesome.
I know the drill. Got it. Thank you. Hey.
What happened? It came loose, or?
No, it came loose, but I think I fixed it.
All right. Okay. Good. Okay,
Yeah,
thank
all
you.
right.
Otherwise, I have another case.
Okay, I think this should be good. All right.
How was your swim?
It was hard. I got my ass handed to me. I've never gone to, and I've swum long. There were 2 lanes. It was long course, and there were like 12 people total. It was completely the very last one, so it was good. Beat down, yeah. But I was out there and I did it. So yeah, that was perfect. It was a nice walk up there, and I was up. I couldn't. I probably woke up earlier than I should. I'll probably pay for it later on this afternoon, but just woke up and thinking about the clock and East Coast time. So it was nice to get out and do something. But yeah, that was a great dinner last night, though. Thank you. That was fun. Oh no, not at all. I was actually. I went straight to my room and I was in bed before 9, so I was totally fine. It's beautiful. It was really nice. Yeah. And it was long course, so that was the kicker. The extra turn doing this, because she told me, I said, well, how fast is the lane swim? And she gave me kind of their that's manageable in my pool, which is, it's meters, but it's short course meters. And it makes a big difference not having an extra push off. Yeah. So, it was good. I'm glad I did it. Get my brain right.
It's a good way to start the day.
It is.
Never been much of a morning exerciser.
Yeah, it's my circadian phenotype. I'm up early anyway, and it's always a good way. And it's just I get cranky if I go too. I'm like Jim McGuff. I've seen him when he goes a day or two without his run or something, and I'm the same way. So. Oh yeah.
This is a list.
I was looking for that, and this might increase my anxiety right before to see all the wow. That's impressive. That's really impressive.
So Ian said you aspire to have 15 minutes of question and answer.
Yeah.
Possible.
Yeah. I'll keep an eye on the clock, and I've got a couple places I can kind of either speed through or cut out if necessary.
So
So.
I'm going to do the Biederman signal.
At 20 minutes after. Scott, stop.
Please come in and take a seat so we may begin.
Oh, I'll keep it. Yeah, great.
Good morning and welcome back to Semel Grand Rounds. Please do complete the evaluation form so that we know that you're here attending, so we can report that information to Dr. Wybrow and the Department of Leadership. Without further ado, we introduce Dr. Jim Packer, who will introduce today's speaker and describe the Dennis Cantwell Memorial.
Good morning, everyone. Welcome to the 19th Annual Dennis Cantwell Memorial Lectureship. I wanted to just give you a little background about this program. We founded this with the Cantwell family in 2000 to honor the memory of Dr. Dennis Cantwell, who was the former director of the Child Psychiatry Fellowship Training Program for some 20 years. And under his leadership, helped establish the program as one of the leading training sites in the United States for child psychiatry. In large part, that was by Dr. Cantwell's own amazing skill as an educator, teacher, and entertainer at the same time. And his impact and signature was found throughout the training program for those 27 years. Dr. Cantwell was also a leading researcher and was among the vanguard of individuals who were bringing empiricism to child mental health research, beginning first with the seminal studies of diagnostic practice for childhood mental disorders, which had been very squishy until the evidence of him and others. His reach in the research room was quite remarkable. Dr. Kollins may mention this, but it included ADHD, an area where he's most likely linked, but also was one of the first to demonstrate that indeed children can develop melancholic major depression. He was involved in studies of anorexia nervosa, the outcome of children with language disorders, and on and on and on. Quite remarkable. Published over 200 papers and authored numerous chapters and texts. And he was as close to a child psychiatry celebrity as we will ever have. Known literally around the world, certainly well known in the U.S. As sort of a raconteur, storyteller, spellbinding lecturer. And so the purpose of this lecture is to honor his memory and legacy by inviting a leading child mental health researcher to speak on an important topic of the day. We're fortunate to have Dr. Scott Kollins join us from Duke. His work represents both the kind of interweaved and extension of Dr. Cantwell's in many areas. Dr. Kollins is an Indiana native, and that explains much of his straightforwardness, good humor, and modesty. He graduated from Duke, received his PhD from Auburn, and has been at Duke now for well over 10 years, where he's established one of the leading ADHD research programs in the United States, as well as a corresponding very sophisticated clinical program. Currently, he also now serves as the Vice Chair for Research Strategy and Development for the Department of Psychiatry. And his work has moved in exciting and interesting ways into looking at the relationship between ADHD and risk for substance abuse and nicotine dependence, and scale in the thinking and work that you'll be sharing with us today, discussing ADHD and related disorders at a population level. So, my pleasure. Welcome, Scott.
Thanks, Jim. All right. Got to turn my mic on. All right. Good. Thank you very much, Jim. It is a pleasure to be here. I'm very happy to come out and see colleagues and meet new ones, but also really, really honored to be able to deliver this memorial lecture. And Jim, right before he introduced me, shared with me the list of the previous speakers for this lecture. And if I wasn't already a little bit anxious to get up, looking at the list of distinguished folks that have come before to speak at this lecture would kind of did the trick. But I'm really happy to be here to talk about things. And as Jim said, I'm gonna spend some time talking about things because I wanted this to be a little bit different than a standard sort of database talk, reviewing the work that I've been specifically involved in. And so I'm gonna talk a little bit more about ideas today and some things, and not just ideas. There are some data to be presented and some things that I'm working on at Duke. But I really wanted this to be an opportunity for us to think a little bit broadly and maybe a little bit outside of the box regarding some of the challenges that we face in managing ADHD patients and how we might be able to move the field forward. So let's see here. By way of disclosures, I have a lot. We stay very busy. None of this is actually going to be very relevant for the talk today, with a possible exception. I might talk about the second one on the left there, the Achilles study, which is a digital medicine company that we've been working with. So what I would like to cover today is, first of all, I want to give a little bit of a background about just what we know about ADHD, and with specific attention to how Dr. Cantwell actually laid down some of the seminal work in this area decades ago, and then to think about and use that as a transition for what are our current challenges and what are the things that we're facing now in the field that we need to try to address. Specifically, I'll sort of focus on two buckets: diagnostic issues and also treatment outcomes and adherence, and then start to think about a model and a model particularly with respect to developing care or improving our care for ADHD patients in a changing healthcare climate, and also in a climate where we're being influenced dramatically, I think, by technological advances. And I actually meant to say, one of my other disclosures is that I'm not a population health researcher, so bear that in mind. But hopefully, I think we can draw some parallels or think about some ways that care of ADHD is relevant for that. So this is an ADHD, or this is a psychiatry grand round, so I'm assuming that most people are familiar in general with this condition, but I want to just kind of level set us and talk a little bit about this. This is a great logo. I had a participant in a trial years ago who came in with this on a T-shirt, and I've loved it ever since then. So we all know that this is one of the most common childhood disorders. That does also persist into adulthood in a significant proportion of cases. It's characterized by developmentally inappropriate levels of inattention, hyperactivity, and impulsivity. I will talk at a little bit more length a little bit later in the talk about prevalence and rates of diagnosis, but in general, again, one of the more common, if not the most common childhood disorder, occurring in about 8% of kids. About roughly half of individuals diagnosed with ADHD are going to persist and have difficulties into adulthood, and that's consistent with other epi studies in adults showing that the prevalence estimates are about 4%. ADHD is a significant risk factor for just about every adverse outcome that you can think of: health outcomes, mental health outcomes, socioeconomic outcomes, educational outcomes. And again, I will kind of highlight this a little bit later. But it is a significant public health problem, and I want to really underscore that fact that I'm not sure that as a field that we are really we're really tackling this and approaching it from the standpoint of how much it actually affects our society. And this is borne out in studies that have looked at cost of illness. This is on the higher end of estimates, but even the lower end of estimates of cost of illness of ADHD in the U.S. alone puts the price tag in the tens of billions of dollars range, and all the way up to over $250 billion for one study that looked at this. So significant impact to our society. So let's talk a little bit about what we just in general. What's the sort of the basis of our knowledge about what ADHD is, and let's start with where it comes from. Some of the causal factors, and the sort of maybe the most straightforward or direct causal factors, of course, genetics. We know that ADHD is highly heritable. All right, this is a condition. There's been a lot of studies over the years, twin studies, family studies. Heritability estimates for ADHD are among the highest of any psychiatric condition, so it's right up there with schizophrenia, and it's approaching heritability estimates for sort of much more sort of objective traits like height. We also know that this runs in families, so siblings and other first-degree relatives and even second-degree relatives are at significantly increased risk for having ADHD if a child in the family also has it. Now, in the last 20 years or so, we've also made a lot of progress that's been concurrent with progress just in our methods to be able to try to understand a little bit more about the molecular genetics of ADHD. And I put this figure up not so you can understand and dissect it, but just to show this is a scatter plot that's looking at as a function of the size of the sample. Just these are all candidate gene studies of ADHD that have been conducted over the years. So this is a study, this is a review paper that was published a couple years ago. There have been more than 300 candidate genes that have been identified as potentially conferring risk for ADHD. Now, of those, about 70% have only been studied in a single study. So that wipes out a lot of these. But there are still a couple dozen candidate genes that have been looked at repeatedly and replicated repeatedly as conferring increased risk for ADHD. Actually, some of the very first candidate gene studies in ADHD were actually conducted here. Dr. Smalley, Dr. McCracken, Dr. McGuff were involved in some of those studies looking at variants of dopamine receptor genes. Most of the other genes that have held up over repeated studies are genes that are involved in monoaminergic neurotransmission, which is not surprising given some other hypotheses about the disorder. But in general, what we've learned is that there are a whole bunch of common variants that probably confer a teeny bit of risk for ADHD. And so, really, certainly from a clinical perspective, all of our advances in molecular genetics they haven't gotten us too far yet. And now, certainly, by identifying genes that are involved, we've learned about we've been able to generate hypotheses about the pathophysiology of the condition. There's some recent work in the last 6 or 7 years that started to hone in on rare variants, where we see the proportion of cases approaching 100% in families in particular where there might be rare variants. And that's actually started to translate a little bit into the development of novel treatments, but we're still a ways away from there. And it's interesting to me in preparing for this talk to start to think again about the contributions of Dr. Cantwell is he knew this almost 50 years ago. So he was involved in some of the very first family studies of ADHD and showed in a sample of kids who had been identified at that time as hyperactive, which is a precursor to our DSM diagnostics, that these kids' family members, both their parents as well as extended family members, were at increased risk for other psychiatric conditions, which is something that has also been replicated, but also specifically that these family members were also at increased risk for hyperactivity itself. So, the way I think about this is the most meaningful thing that we know from genetic studies from a clinical perspective, we've known for 50 years. And that is that this runs in families, and if I have a case that I'm seeing in front of me, and there's a rich family history for ADHD versus a case where there's not, that's going to guide my thinking in terms of diagnostic decision making. So moving on then in terms, again, overview, thinking about the, what we know about ADHD now. We've learned a lot also about the neurobiological basis of ADHD. And just like with genetics, this has paralleled the methodological advances that have been made, particularly with neuroimaging modalities. And there are a few things that have been, a few sort of key findings, I think, that are that have taught us a lot about the neurobiological basis of ADHD. One of the more robust findings is that, and this is done with fMRI and MRI studies, has shown that a particular network in the brain, the default mode network, seems to be both structurally and functionally different in individuals with ADHD. Now, this is a network that when we're at rest, it's active. And so there are a number of, I mean, I've heard of it as described as sort of an oscillator or a heartbeat of the brain, and that when you're at rest, this is a network that sort of is active, stays ready. As soon as you engage in a task, this network sort of shuts down and its activity decreases, presumably to allow resources to bring other networks online that will help to engage in those tasks. And what we see with ADHD patients is that not only is the structural integrity, the connectivity of that network decreased in ADHD patients versus non-ADHD patients. In functional studies, when you present a task and this network in a typically developing or a non-ADHD person shuts off and these other networks come online, that doesn't happen as much for the ADHD patients. It doesn't shut down as much. And so again, my more simple-minded way of interpreting that is that the brains with respect to this particular network of folks with ADHD are not functioning as efficiently as those without the condition. Now, another finding that's been replicated and is really thought to be sort of a truth in ADHD is that another feature structurally for patients with ADHD is that they have a maturational lag in their cortical development. So these are slides from a study published by Philip Shaw. It's been a while now, but it was a real landmark study showing that there, on average, was about a 2-year delay in cortical maturation for ADHD patients versus controls. And this is also consistent with what we see clinically. And a lot of times the kids in the clinic that we see, they present as immature. They present as immature in their executive functioning and their social functioning. And this is sort of consistent with this notion of maturational lag in the cortex. This is a figure just from a large-scale meta-analysis of fMRI studies that have been conducted, hundreds of them. And the take-home message here is that across the board, across ages, kids, adolescents, adults, what you see is in general, replicated findings that we see differences in function in brain areas that subserve things that we would expect to be affected by ADHD, like sustained attention, like working memory, and other aspects of executive functioning. So it doesn't show up too well, but there are color codes on there, and it's a really nice article that's just a nice review of all the fMRI studies. And then finally, this is a study that we were involved with from a few years back, looking specifically at dopamine functioning as a potential sort of distinguisher of ADHD. This is a large PET study in adults with ADHD showing that both presynaptic and postsynaptic dopamine receptor density was lower in adults with ADHD compared to their matched non-ADHD controls. So we looked at both the dopamine transporter presynaptically, the D2 receptor postsynaptically, and showed that there were differences. And across the entire sample, so there are almost 100 people in this study, we also found significant correlations between the levels of occupancy and self-reported ADHD symptoms. So the lower the density, the higher self-reported symptoms, and that was true both in the patients as well as in the controls. So again, these are sort of much of what we know in summary terms about the neurobiology of ADHD. Now again, to look back, Dennis Cantwell did a lot of work in this area again, almost 50 years ago now, and did some of the earliest work on neurobiological differences between hyperactive kids and non-hyperactive kids. The table on the right, or on the left rather, describes a study looking at just EEG abnormalities in hyperactive and control kids and showing that they're different, which is, it's a different method, it's a different measure, but it's very similar to what we've seen in the decades since then. And then really, really importantly, and this is work that I wasn't aware of until I started sort of looking into it to prep for this talk. He published a couple of studies showing that these markers could actually be used to predict treatment response. So kids who had more EEG abnormalities or more neurological soft signs actually did better in treatment than their hyperactive peers who had more normal EEG functioning or fewer soft signs. That's really important. We don't do that now. We don't have MRI predictors of which kids are going to respond to what kinds of treatment. So this was really, really seminal work. So just to highlight that. All right, so I already talked about that. So let me say one other thing about the treatment of ADHD. So in general, we have a lot of treatments for ADHD. There are 25 FDA-approved products for the treatment of ADHD. Most of them are stimulants. They're variants of either or formulation differences of either methylphenidate or amphetamine. We have a range of non-pharmacological treatments that have evidence to support the treatment of ADHD. And what we know, and what was originally established in part from the MTA study, the multimodal treatment study of ADHD, which was initiated in the late 90s. First data-based papers started coming out of that in the early 2000s. Well, actually, the first papers that came out from the MTA showed that, or reported that that medication, independent of whether or not you added behavioral therapy, was effective for reducing ADHD symptoms. So this is a comparative treatment study with behavior therapy alone, medication alone, combination, or treatment as usual out in the community. And the first reports were that the medication, either by itself or with behavior therapy, reduced symptoms better than the behavioral only or the treatment as usual group. Shortly after the sort of first primary outcome paper came out, this was a study published by Keith Connors, who was one of my mentors and hired me at Duke, where they took all of the other measures that were included in the MTA study. So not just the symptom outcomes, but other measures of functioning and impairment, and conducted a PCA, principal components analysis, to sort of pull or reduce the data. And what he found when you looked at those outcomes were actually the combination treatment was superior to either medication or behavioral therapy alone. And this is I spent a little bit of time on this because it is a theme I'm going to talk about a little bit later. The bottom line here, though, in terms of overall ADHD management, combination treatment with medication and non-medication treatment for a number of years has been recognized as sort of the ideal gold standard. And this is borne out. So this is actually a nice, very timely for me in this talk, Viewpoint article that came out by Tanya Froelich in JAMA Pediatrics just last month, talking about the importance of multimodal treatment for the management of ADHD, and highlighted the important part here that optimal outcomes across a broad range of functional domains can be obtained by combining medication and behavioral intervention. So really driving this point home. Now, let's look back again, 1979, so now nearly 40 years ago. Pretty much the same conclusion. So some of the work that Dennis Cantwell did, along with Jerome Satterfield, or James Satterfield rather, showing or touting the benefits of multimodal treatment and the importance of combining those. So we've come, in some ways, we've come a long way, and we've learned a lot about ADHD. We know a lot about the molecular genetics, or a lot more than we did 20 or 30 years ago. We've gotten a lot of advances in the neurobiology, but really, and we've sort of recognized that you need to take a multimodal approach to treating these kids. These are things that we've known for a really long time, and we are still faced with some significant challenges in managing these kids. And ADHD ADHD still exerts this substantial toll on our society, on the families, and on the patients that we work with on a day-to-day basis. So where do we go from here? How can we kind of stop spinning on the wheel of just kind of repeating things that we've known for a really long time and really think about paradigm shifts and moving the field forward? So I want to spend the rest of the time kind of talking about what I see are some of the biggest challenges that face us as people taking care of individuals with ADHD, and then also some ideas about what we might be able to do about it. And I also just to highlight the impact, further highlight the impact that ADHD has on outcomes. So on the left are data from a study with children showing, I mentioned before, that pretty much every adverse outcome that you can think of, you have an increased risk for it if you have ADHD. So these are all odds ratios of having that outcome compared to control people, and it varies widely. Mental health outcomes, substance use outcomes, criminal justice involvement, motor vehicle accidents. What I'm not showing on here, educational outcomes. I'm not showing the health outcomes. I'll talk a little bit about that later. And then on the right, this is what, when I think about some of the stuff I'm going to talk to you guys about in a little bit, when I think about the pitch to be made to a funding agency maybe, but to my health system, about why we should be thinking about refining or changing the way we think about ADHD from a health system, population health management perspective. These are the data that I think about. These are registry data from Scandinavia showing if you have ADHD, you are at an increased risk for premature death. So from the standpoint of population management, where the goal is going to be to keep our populations healthy, dying prematurely does not, that's not one of our goals there, obviously. And especially if you are diagnosed a little bit later in life. So if you're diagnosed, in this study, the finding, if you're diagnosed at age 17 or above, then you are 4.25 times more likely to die prematurely. And this controls for a whole host of other factors. So this is a really significant finding, and again, kind of underscoring the point about why we need to change what we're doing, and that we should be thinking about this from a public health perspective. So as I mentioned in the overview, I'm going to talk about kind of two buckets about where I see challenges and where we may have opportunities to intervene. The first is diagnostic challenges. And there are a number of them here. And so one of the things that is, these are oft-cited data from the CDC. These were actually published in 2014. The data continue to be updated, and you can get these from the CDC. I actually pulled these down from the CDC website. What you're looking at here from bottom to top is across time, starting in 2003, and the top set of figures is 2011, showing by age group the rates of diagnosis of ADHD in the United States. And so what you'll see is just that that V gets wider, which means there is a substantial and statistically significant increase in the rates of diagnosis in the United States across the board, such that by the time, and you can't see it too well, but by the time you get to, in 2011, at about age 12 or above, if you're a boy, 1 in 5 boys age 12 or above in the United States are diagnosed with ADHD. Now, it's really, really important to keep in mind the methodology for this, for where these data came from. This is a population-based survey where caregivers were asked, do you have a child in your house? And if so, have you ever been told by a healthcare professional that your child has ADHD? So this is not prevalence. I want to emphasize that. This is rates of diagnosis. And let's compare and contrast that with true prevalence in the population. So this is a really nice review by Guillermo Palanchik from Brazil, looking worldwide. Actually, this was worldwide. Looking at prevalence studies, epidemiologically based prevalence studies where diagnosis was actually confirmed. And what I will call your attention to is the solid line. That is over time, that is the prevalence estimates from all of these different studies with 95% confidence intervals in dotted lines. So if you see from the mid-'80s to the early 2010s, it's flat. There's no change in the true prevalence of diagnosis or of the disorder in our population. However, that's very different from the rates of diagnosis. That is a problem. That is clearly a problem. Now, the sort of easy conclusion to draw from that is, well, we're overdiagnosing. which we are, and there's no question about that. There are more kids that are being diagnosed than probably have the condition, but it's also, and I throw this caveat out, I'm not going to talk about it as much today, but there are lots of kids who probably meet criteria for ADHD who don't get a diagnosis. So it's really, the problem is a mismatch between diagnosis and who has it and who actually gets the diagnosis. And where does this mismatch come from? How is it that we've got these rates of diagnosis? I mean, the prevalence estimates from EPI studies sit at about 7%. And yet we've got 1 in 5 boys above a certain age who are meeting criteria. So where does this mismatch come from? Some of the more sensationalistic explanations for this are that this is the result of big pharma. This is actually this is the sort of premise of this book. Alan Schwartz is a New York Times journalist. He's written a lot of very, I would say, inflammatory and controversial articles for the Times. Wrote this book basically arguing that this increase in diagnostic rates is pretty much solely attributable to big pharma trying to create an epidemic so that they could then treat it. Now, I would not say that the pharmaceutical industry is sort of above reproach with respect to their marketing and some of the things that they've done and how that might contribute to this rate of increase in rate of diagnosis. But I would argue that a potentially more parsimonious explanation for this mismatch between diagnosis rates and true prevalence rates is that it's really hard to make a good diagnosis of ADHD. It takes time and it takes a lot of information gathering. 80% or more of ADHD is managed in primary care. So being able to adhere to the DSM criteria, which the American Academy of Pediatrics guidelines recommend that pediatricians follow if they're going to make a diagnosis of ADHD, which means getting information from multiple sources, documenting that symptoms and impairment are occurring in multiple settings, documenting the chronicity of the condition over time, and also making sure and ruling out and doing differential diagnosis to make sure that there's not something else accounting for that. And doing all that in 17.9 minutes, which is about the average well child visit for a pediatric practice. So that's obviously, that's going to be really hard. And when we, in my specialty program, we get 50 pages of developmental history and behavioral rating scales. Then the patients come in and they spend a little bit more time on structured diagnostic interviews, and then we meet with them for a couple of hours. And we still sometimes struggle with whether or not a child has ADHD. So how are we going to expect a primary care provider in such limited amount of time to be able to make a similar or to be able to reliably make a diagnosis? And because primary care providers, I would 99.9% of them, their primary thing that they're interested in is taking care of their patients. Why not sort of err in the direction of a diagnosis of ADHD, because it opens up some doors to potentially try to treat that. So that I think that probably accounts for more of this mismatch in diagnostic and prevalence rates. Than anything else. But what that means is that, or it raises the question then about how do we address that, and how can we really start to think about changing that so that we can better manage the kids with ADHD. And I think there's at least a couple of ways that I'll submit to you that we can think about changing the paradigm around diagnosis. The first is that we can facilitate implementation of those best practices. So I mentioned that the AAP recommends that pediatricians follow these guidelines. This is an example, I think, and this also is starting, and I'll talk more about this in a few minutes, but this is starting to leverage technology in a way to improve our diagnostic practices. So this is just snapshots from a very innovative web portal. It was actually developed by a former colleague of mine, Jeff Epstein, who's now at the University of Cincinnati, and this idea actually fell directly out of the MTA study. Jeff UCF was involved, continues to be involved with the MTA study. But this is a portal that helps primary care providers gather, distill, and organize information to help them both make diagnosis, but also help to manage and monitor treatment over time. So it consolidates rating scales, it algorithmically and sort of automatically scores and provides feedback to the pediatricians to make that process a little bit easier. Now, I don't think that this portal by itself is going to be the thing that we still have a ways to go, but I think this is a novel example of taking advantage of something, using technology to help, like I said, facilitate the implementation of those best practices. So another thing that we can do, and this is something that I've been spending a lot more time thinking about, is thinking about how we might refine the phenotype and what is it about ADHD and how we measure it. How can we tweak that to do a better job of characterizing the condition moving forward? Even in our sort of gold standard assessment, when we spend all this time with the families, we're still really only getting kind of a slice of a small bit of sampling of behavior and functioning of the kids, and the adults for that matter, that we're working with. So we might have the sampling slice that the parents have in mind when they fill out all the forms before they come in, and then we've got we've got another chunk when they actually come to the clinic. The primary care docs who are making these diagnoses have an even tinier sliver to work with. But as we move into a world where we can measure and monitor things in real time constantly, this opens up all sorts of possibilities. I mean, we've known for a long time, there's just a nice meta-analysis of studies looking at using actigraphy, so using just activity monitors to distinguish ADHD from non-ADHD. We don't have enough data to support them as being diagnostically useful, but it can certainly pull in some additional information. And if we start to think about things other than just motor activity, things like sleep, things like physiological activity, or even just real-time sampling of behavior. We know that ADHD, we've done some other work using EMA in adults. ADHD symptoms vary across time and time of day. So and it actually varies across place depending on where people are. So being able to capture some of that and increase the resolution of our sampling frame to understand the behaviors that we're assessing could be really, really valuable. I'm not sure that this is going to lead to the next iteration of the DSM incorporating some of this into the diagnostic criteria, but it can certainly help us clinically to help hone in on the things that might be useful from a treatment standpoint. Now, as I think I've talked to a lot of folks that are already involved in a lot of cool stuff here in this space, and one of the things that always seems to come up is as we move towards collecting these kinds of data, there's a lot of data. If you start to think about sampling rates at a minute or even 2 minutes over a course of weeks, that is an enormous amount of data. So we've also got to take advantage of advances and sort of sophisticated techniques for being able to analyze those data, to pull signal out of those data using some of these techniques. So let me give you 2 examples of how we're starting to leverage some of this in our clinic. So the first has to do with using text and voice sampling and using natural language processing to start to see if we can do some prediction of clinical outcomes in what we're starting with is diagnosis. Now, there's a lot of work in this area already. There's work using text and voice samples to predict psychosis and depression and PTSD and bipolar disorder. To our knowledge, nobody's been doing this in the ADHD space yet. We started off, and this can be gathered. It can be gathered remotely through a web portal, through an app, through a phone call. It could be high tech or low tech. It could also what we've been using is just text. So we haven't done this prospectively yet. We're just about lined up to do this, but we wanted to see retrospectively if we could do this. So we have about 700 patients in a database that have signed a release for them to use their data. These are adult patients. We've got a bunch in the kids too, and we're starting to look at those data as well. One of the first questions on one of the questionnaires that we ask them is, what is going on in your life that leads you to believe you have ADHD? And they free text a response, and not because we were anticipating doing this, but serendipitously, we databased verbatim every single one of those responses. And so now I have a postdoc who is a very talented guy, Matt Engelhardt. He's an MD, PhD. His PhD is in systems engineering. He's a machine learning and data science guy. So he's been working with this data set of this text. And what he's shown is that just from that single sampling of text, that is significantly correlated with behavioral ratings of both inattention and hyperactivity. And there's depending on what they write, it distinguishes which is which. Now, we haven't quite gotten to the point where we're using just that single sampling of text to actually predict who has a diagnosis versus who doesn't, because these are all people that come into our clinic wondering if they have ADHD and seeking an assessment. But that is our next step. And then we can also look at who has ADHD plus comorbidity and whatnot. And then what we're also planning on doing moving forward is adding in voice. So in addition to just text, because there's a lot of really interesting work ongoing and using voice and pitch and cadence and other features of voice to predict mental health outcomes. So another area that we're very interested in is in sleep, and we're interested in general in all of the data that we can gather using wearables. But what we've really honed in on is sleep. Some of this work is, well, the majority of this work is driven by another really talented junior faculty member in our group, Jessica Lunsford Avery. She has a K award to look at sleep in ADHD and non-ADHD adolescents. She's doing at-home polysomnography with these teenagers. She's also doing neurocognitive testing after their sleep to look at the sleep architecture, look for differences between the group, and then also to look to see what the relationship is between sleep parameters and neurocognitive functioning. But what she's also doing now is having these kids wear, before they do their at-home polysomnography, having them wear some pretty advanced activity monitors. And these are monitors that not only measure at a pretty high resolution activity, but it also measures ambient light, so we can get a lot of information about circadian rhythm. And what we hope to do then is to start to really mine those data for predictive purposes, both to see what's distinguishing the clinical versus non-clinical groups, but then also looking at some of our clinical outcomes. And just to give you an idea, what I'm going to show you is not from an ADHD sample, but just an example of one of the sleep parameters that we're really interested in. We're really interested in sleep regularity. So this is an index. It's a relatively new and novel index. There's just the first paper describing it was published late last year. This is an index of sleep that effectively looks on a day-to-day basis the probability at any 2 points in time whether or not you're asleep at the same time on day 1 versus day 2, and it's kind of a rolling probability. So 0.5 is the worst you can be because on any day at any given point during the day, it's a 50% chance that you're asleep, 50% chance you're awake. So it's chance, and then 1 means you are 100% predictable. You go to bed at exactly the same time, fall asleep, and you wake up at exactly the same time. And what that looks like is this. Kind of wishing I had my pointer now, but the irregular sleepers on the left are people, and each day is a row. So what you'll see is the irregular sleepers across days, they're mixed up. The regular sleepers are very consistent. And the interesting thing about these two sort of exemplar cases is that the regular and irregular sleepers have the same overall sleep duration. So they're matched for the overall amount of sleep that they're getting in a day. And those two things are not correlated. And so this is a scatter plot of this index in a big publicly available data set called the MESA data set. It's a study of older adults looking at atherosclerosis. And what we found, the original study that looked at this index showed that this index of sleep predicted GPA among Harvard undergrads. So we're looking at this in the MESA data set, and we're showing that this is related to cardiovascular outcomes, which is not, other groups have shown that sleep parameters are predictive of cardiovascular outcomes, but this is a new one. But we really think that this could be an important sort of phenotype for ADHD, and so this is a direction that we're going to go. All right, so I want to make sure that we have time for some questions. So I'm going to talk a little bit briefly about treatment outcomes, because this is the other big bucket, and I'll make a few points. So these are data, let me just kind of talk you through this, because I mentioned before, and I mentioned a couple times, we have treatments that work. We have we have hundreds of studies for pharmacological treatments of ADHD that show acute short-term effects. We've got 25 products on the market now that have passed the muster of FDA approval and have made it to market. We also have many non-pharmacological treatments that have evidence for treatment. And yet, if we look over time, the long-term treatment outcome data are pretty equivocal. So if you look, on the left is a review that clumped in all sorts of different kinds of outcomes. So it was sort of outcome agnostic. But basically the point here is that especially if you're looking at monotherapy, either medication alone or behavioral therapy alone, long-term outcomes are pretty poor. And if you look, the longer you go, the worse and the sort of bleaker the picture becomes, because if you have a study that's followed kids for at least 3 years, almost half are showing no improvement from baseline. All right? Again, why is this the case? We've got treatments that we think at least acutely work, and yet 3 years out, almost half of kids don't benefit from ongoing treatment. On the right is just a similar story, but specific to academic outcomes. Now, we can also sort of learn about these patterns a little bit from looking at again, at data from CDC, recognizing that these are confounded by the fact that this is probably lots of kids that actually don't truly meet the diagnosis of ADHD, but only about a third of kids who get a diagnosis of ADHD are actually getting what we know works the best, which is combination treatment. And there's actually a substantial minority of kids that get no treatment, even though their kids have been diagnosed with ADHD. That's problematic. And there's also pretty substantial geographical variability here, probably owing to differences in healthcare regulations and laws across states. We also know that kids, that families in general don't stay on treatment very well, even within a year. This is just one study showing a survival plot of how long people would go before they had at least a 30-day gap in their medication treatment. So after a year, about 12% of families, of kids, had consistently been treated without a 30-day gap. And if you look at other claim studies, you see a similar picture where persistence and adherence rates on treatment are, after a year, are notoriously low, 10%, 20%, 30%. I would, so again, to kind of move on and think about how we can address this, I think that one of the biggest problems that we're facing is that we don't conceptualize, we don't treat, we don't manage ADHD as a chronic condition. Care for ADHD is usually fragmented. The average duration or the average interval from when a kid gets a diagnosis in primary care to when they follow up for their next follow-up appointment, even when medication is initiated, is a little less than 3 months. 3 months from the time you're told your child has a condition that there's a 50% chance will persist for the rest of their life, and we're starting a treatment and we'll see in 3 months. That's not going to be very effective. In the minority of cases that actually get multimodal treatment, they go out and get behavioral therapy, that's going to be delivered by somebody else, if you're very lucky, maybe in the same practice, certainly not the same provider, but more likely outside the practice. That care is not integrated. It's not managed together. We don't think of ADHD as a chronic condition, and it is. It persists across the lifespan, and we have ways and we have models for thinking about managing chronic childhood conditions. This is a model that's published back in the early 2000s, focused on, I think, diabetes and asthma. But we can take the same sort of thinking, especially, and my argument is I think that our healthcare climate and our climate of where we are in terms of leveraging technology can really support a move or a pivot to how we think about conceptualizing ADHD as a chronic condition. This is a nice review paper, although it hasn't been cited at all, taking that same chronic care model and really talking about how we might be able to implement it from an ADHD perspective. And I'll talk about just a couple things real quick. These are just different pillars of this chronic care model where you need decision support. You've got to think about care integration and delivery design. You've got to think about information systems, family and self-management support. There is work ongoing that I think exemplifies pieces of this model. I already talked before about the decision support and the cool work that's being done at Cincinnati, because this program is not only does it help with diagnosis, as I mentioned before, but it also helps providers track treatment over time and get rating scales delivered to them from parents and teachers, and to be able to make database decisions about dose titration and to do it more regularly and not wait 3 months. We also, there's a lot of interesting work ongoing in developing innovative collaborative care models. Narissa Bauer at the University of Indiana, she's a developmental and behavioral pediatrician, has developed some really neat and innovative ways to combine medication management visits with parent behavioral training. So parents come in groups for the same, if they want their meds refilled, they come in and they get parent behavioral management. And she's shown that this improves the child outcomes, it improves quality of life, the parents really enjoy it. And she's also, even though this has been developed in the context of a research study, she's shown that it's sustainable. So you can bill for this in ways that make it sustainable. So moving on, let me talk about just a couple of things here with the kind of increasing engagement with families over time. We do have lots of advances ongoing in digital health. There are, we've talked about sort of the limitations a little bit of being able to access behavioral interventions for ADHD, and there's work ongoing now that demonstrating that you can feasibly and effectively implement parent behavioral training for kids over the internet. I know there's also ongoing work now looking at app-based approaches to doing parent behavior management. This is also just it's another variant of thinking about mobily delivered treatment. These are results from a proof of concept study with a game-based intervention for attention in kids with ADHD. So this is the Achille product that I mentioned in my disclosures. We were involved in this research. They just finished a large-scale multi-site RCT, again showing that this at-home tablet-delivered treatment can improve attention for kids with ADHD. Both of these really highlight what we might be able to do from the standpoint of access to alternative kinds of treatments for kids with ADHD. Okay, so I want to make sure we have time for questions. So I'm going to skip, and maybe it'll come up in questions. Sorry, Erica. I'm just kidding. I told her I was going to try not to flip through slides and say, let me just get to the end here, but I want to make sure we have time for questions. So we've got a lot of challenges facing us, but I think I made my sort of take-home point a minute ago, which I think we're at a time, both with changes in healthcare systems, as well as technology, that we are really at an exciting point where we can make some substantial changes. And some of the folks that I've already talked to here are working this area. I hope we can all kind of keep this dialogue going, because it's really exciting to me, and it's guiding the way that I think about both our research and our clinical practice. So thank you guys again for inviting me, and I'm happy to have some discussion.
Thank you very much, Scott. I guess my first question is, do you think we have fallen down on our responsibility of educating all of those primary care folks that are doing the majority of the diagnosis and these prescription writing? Yeah,
well, I mean, I don't know. I'm not sure who's fallen down. I don't know if it's, I'm not sure whose responsibility is. I think we talked a little bit about it last night, but that's an opportunity, and it's actually an opportunity, again, that I think we can, think about novel ways of delivering that training or that education through CME. I am amazed when I work with, if I would have had time, I would have told you about a new project that we're implementing in primary care where we're screening and for ADHD. And I've been impressed and amazed at how engaged they are and how much they want to learn about, not just about because we do a little bit of work specifically on ADHD, but they want to take better care of their patients, and they know where their gaps in understanding are. So I think that's I don't know if that's working at the level of AAP in conjunction with ACAP, but I think that there's an opportunity there to increase the knowledge base for those primary care providers. Yes, ma'am. Oh, can we get a mic back there?
Thank you very much. Yeah, I've been very aware of the difficulty with the medication for ADHD and the appetite suppressant and even combined drugs. I'm wondering, is anything going on about that? Because it really seems to be a huge problem.
Yeah, it is, and so I know that the MTA study demonstrated this, and I think it's been replicated since then. And one of the things that, and I think you started to ask the question, one of the things that you get with combined treatment is you actually get similar outcomes at a lower dose. So to the extent that those kinds of adverse events that you get particularly with stimulants that are dose related, you might be able to help relieve some of those by implementing multimodal treatment. Beyond that, it's most side effects are dose related, and so there's only so far you can push a dose before you are not going to be able to push it further. So I think that what that underscores for me is we just got to continue to think about and acknowledge what the limitations of pharmacotherapy are, and to teach providers about that this is going to help with this this sliver of functioning, but it's not going to help with everything. So I think it's a really important question.
Hi, thanks for your talk.
Sure.
When you were talking about the differences between the true prevalence rates and the diagnostic rates in the community, I wondered about differences in dimensions versus categories in relation to ADHD. Is it possible that people are thinking about them as dimensions, just setting the cut point as the different one?
Yes, I think that's so. Maybe some of those increases, the increases in diagnostic rates that we see are, sub-threshold kids that are, they're 2 standard deviations above the mean, but not 3, or maybe 1.5 standard deviations above the mean. That could be driving it. I mean, certainly. Again, most providers are not, they're not recklessly making diagnoses of ADHD. So something is driving them to say, yes, this child has ADHD, even though they might not have been able to, not any fault of their own, not go through all the DSM criteria. So, but I think that's a really interesting. It's a really interesting question to think about. What are the things that lead to? There has been a fair bit of work on just what typical primary care providers, like what do they do to make the diagnosis, and it's pretty limited. But that makes me think it would be very interesting to even take the most, what we would say is the worst practice, which is you talk to the parent for a little bit and then you make a diagnosis. But what is that provider pulling out of that conversation that is leading them to make a diagnosis, and is it symptom based? So that's a really good question.
And as a follow-up, is there any progress in terms of the sort of RDoC way of thinking about ADHD,
a little bit. It's funny. I cut out like 4 slides that had RDoC all over them. I don't. There's certainly been a lot of research in that area that is honed in on the different sort of pillars of the RDoC framework. I'm not sure that there's been anything conclusive that's fallen out of that beyond that's more meaningful than, for example, some of the neurobiological sort of summary that I showed you. Yep.
That was a really excellent talk.
Thanks.
Did you, and I missed the first couple of minutes, I'm sorry for that, but don't think you addressed this. Could you talk a little bit more about the role of schools in identifying cases and as a site for intervention?
Oh yeah, I didn't talk about that, and I think that's it should be one of the key places to identify and help refer and help embed services that would help to streamline that. One of the things, though, well, not though, I think by the time that kids are identified as potentially having difficulties in their school age years, not that this is not, that we should not think about novel ways of identifying and providing services in schools, but I really think our emphasis should be earlier, because we want to arrest that trajectory before it's to the snowball has built up to the point where it's now impacting academic performance and social performance. And I think there's some ways we could intervene. Not that that's going to happen in 100% of the cases. So, you know, I think that I heard a little bit yesterday talking to some folks here. We're starting to think about this at Duke with this primary care screening project that we're working on, which is integrating school-based data with health data to help to understand outcomes and track outcomes. That, I think, those kinds of approaches, and it sounds like there's some similar things going on here. Those kinds of approaches, I think, build a lot of ammunition to make an argument for enhancing services and so forth. It's also very instructive for me listening yesterday. It highlights regional and state and geographic differences in what can be done in the schools. And a lot more, it sounds like, can be done in the schools in California than in North Carolina, unfortunately, in terms of actual interventions, willingness to partner, resources to be able to do that. But I think it's a great point, and it's certainly, you know, it's what kids' jobs are, is to go to school. So most of them are there, and we should be thinking about how to work there too.
Thank you so much.
Yeah, my pleasure. Get myself. Got a whole bunch of wires on me.